How can your gallbladder ruin your life? Hi, it's Dr. Van here. Let's talk about some rare complications of gallstones. If you want to learn more about gallstones first, check out the links below for more videos. One problem that gallstones can cause is Mirizzi syndrome. This occurs when gallstones get impacted in the cystic duct or neck of the gallbladder, then causes compression on the common hepatic ducts. This is rare and occurs in less than 1% of people with gallstones, which equates to an incidence of less than 1 in 10,000. It is more likely to occur in those with large stones, low and tortuous cystic ducts, and in presence of gallbladder cancer. Mirizzi syndrome can further progress to a fistula in the following fashion. The impacted stone results in inflammation, development of adhesions between the gallbladder and surrounding structures, including bile duct and small bowel. Pressure from the stone causes pressure necrosis and an eventual erosion of the stone through the gallbladder wall into the surrounding structure, being bile duct or small bowel, resulting in a fistula. The degree of Mirizzi syndrome can be classified according to Send's classification. Type 1 represents around 10%. This is a simple external compression causing common bile duct obstruction. Type 2 represents around 40%. This is the start of a fistula with the stone eroding through 1/3 of the common bile duct circumference. Type 3 represents around 45%. This is the continuation of a fistula with the stone eroding between 1/3 to 2/3 of the common bile duct circumference. Type 4 represents around 5%. This is the complete destruction of the common bile duct wall, resulting in the formation of a cholecystobiliary fistula. Type 5 represents less than 1%. This is the complete erosion of a stone through the gallbladder into the small bowel, resulting in a cholecystoenteric fistula, in addition to a type 1 to 4 finding. The typical presentation of Mirizzi syndrome and the subsequent investigations required are similar to that of cholecystitis or cholangitis. Please see the link below to my other videos in the comment section for more details. Diagnosis is typically made on CT or MRCP findings. The treatment depends on the type. However, in all cases, if there is evidence of biliary obstruction, an ERCP, sphincterotomy, and stent insertion should be performed first to relieve the biliary obstruction. The subsequent management are as follows. Type 1. Cholecystectomy with stone extraction. This is sufficient to cure the disease. Type 2. Cholecystectomy plus common bile duct exploration plus primary fistula closure, either with absorbable suture or a choledocoplasty, which is a repair using a gallbladder remnant. Type 3. Cholecystectomy plus common bile duct exploration plus choledocoplasty or the formation of a new biliary enteric anastomosis, which includes choledochoduodestomy and choledochojejunostomy to form a new biliary enteric tract. Type 4 and 5. Cholecystectomy plus common bile duct exploration plus a new biliary enteric anastomosis. So in summary, Mirizzi syndrome involves a gallbladder fistulating into the bile ducts and is managed by the removal of the gallbladder and repair of the fistula, either with closure of the defect or formation of a new joint between the bile duct and the small bowel. Mirizzi syndrome is also related to another rare condition known as Barnard syndrome, which is also known as gallstone ileus. This occurs when a gallstone makes its way into the small bowel and gets stuck, causing a small bowel obstruction. This is a very rare cause of small bowel obstruction and a rare complication of cholecystitis. It occurs more frequently in elderly females. It occurs when an impacted gallstone erodes through an inflamed gallbladder into the small bowel, much like the process of Mirizzi syndrome, and hence, unsurprisingly, is related to Mirizzi syndrome in over 90% of cases. The stone then gets impacted in areas of narrowing, such as the ileus valve or at a Meckel's diverticulum, to cause small bowel obstruction. And because of this pathology, patients will present with symptoms of both cholecystitis and small bowel obstruction, being right upper quadrant pain, distension, nausea, vomiting, and obstipation, which is the absence of any bowel motions or flatus. Occasionally, the gallstone migrates proximally and obstructs the pylorus or duodenum, causing a gastric outlet obstruction, the symptoms of which may be very similar. Investigations will be the same as that for anyone suspected with small bowel obstruction, being blood tests and a CT scan. A classic finding on CT is the Wriggler triad, being small bowel obstruction, gas in the biliary system, known as pneumobilia, and a calcified stone in the bowel. Patients with gallstone ileus require treatment for both cholecystitis and small bowel obstruction, being broad-spectrum antibiotics plus fluid resuscitation plus support of any organ failure. The definitive treatment involves an operation with three main components. 1. Remove the stone. 2. Check for more stones. And 3. Consider the underlying cholecystoenteric fistula. This involves a midline laparotomy, longitudinal enterotomy along the antimesenteric border proximal to the stone to extract the stone. This incision is then closed transversely to ensure maximum lumen diameter is retained. The entire small bowel should then be checked because in 10% of cases there are concurrent stones, and it will be very embarrassing to need to do the same operation again the next day. These subsequent stones are removed in the same fashion as the first stone. In most cases, leave the gallbladder and cholecystoenteric fistula alone because patients are typically very sick and not suited for a long complex operation. Even without the additional complex operation, gallstone ileus has a high mortality rate of 10 to 30%. If the patient improves from this acute episode, these fistulas can be reassessed because sometimes they may close themselves spontaneously, or otherwise the patient can be assessed for an elective cholecystectomy with fistula repair at a later date. Well, I hope that you have learned something new. Please listen to this again to reinforce your learnings, because repetition is a key part to learning new information. And please remember to like, subscribe, share, and comment for more videos.